Welcome and thank you for attending. This event is brought to you by CooperSurgical, a leading provider of medical devices for women's healthcare. For 30 years, CooperSurgical has worked with healthcare providers to provide highly effective clinic and practice-based contraceptive, surgical, and obstetric solutions. To complement our portfolio of trusted and reliable medical devices, we have also broadened our offerings, investing in the areas of reproductive genomics and in vitro fertilization. We are fully committed to helping improve the delivery of healthcare to women and their families. CooperSurgical manufactures over 600 clinically relevant medical devices used by healthcare providers in offices, clinics, operating rooms, labor and delivery suites, and reproductive IVF clinics worldwide. Clinicians overwhelmingly say they trust our products for their reliability, innovation, and efficiency. Here are some other interesting facts you may not know about CooperSurgical. Since our inception in 1990, our focus has always been women's healthcare. With more than 600 medical devices and over 3,200 product numbers across a broad range of market segments, physicians know and trust our products. We ship over 1,400 orders per day, of which 99.7% are shipped the same day. Our customer service department handles over 2,000 inquiries per day. We employ 1,750 people worldwide. We are pleased to provide this educational opportunity on behalf of CooperSurgical.
Welcome and thank you for participating in tonight's event. My name is Alan Chips, and I'll be the meeting manager for this evening's event. A couple of notes on how the presentation will run. We'll have approximately 35-minute time limit for the presentation, which will be followed by a 15-minute Q&A session with Dr. Schwartz. To submit a question during the presentation, please click the Ask a Question button located at the bottom of the player window and fill out the form. If we aren't able to get to your question tonight, you will receive a response from CooperSurgical after tonight's event. Tonight's presentation is entitled Direct Visualization Can Transform Your Practice, presented by Dr. David B. Schwartz. Dr. Schwartz is board certified in obstetrics and gynecology and is a fellow of the American College of Obstetrics and Gynecology. And I'll turn it over to you, Dr. Schwartz.
Well, welcome everybody, and it's a pleasure to be here to discuss direct visualization and how it can transform your practice in taking care of women in this time of COVID and after. I'm David Schwartz. I'm an OB-GYN in Cincinnati, Ohio, and I'm a paid consultant and speaker for CooperSurgical, Inc. The ability to look inside a uterus and to diagnose the abnormalities that are there affecting the reproductive health of our patients is an invaluable tool for the modern gynecologist. In this time of COVID, we haven't been able to gain access to the hospital as often as we want to. And so doing that in our office, in the office environment, is not only a convenience for the patient and for the surgeon, but it's for a way to us to continue practicing safe and effective healthcare for our patients. And what we have found is another tremendous benefit, the overall reduction in healthcare costs. Abnormal bleeding is going to affect 1 out of 3 patients that present to your practice. And it is a very common problem. We used to call it menorrhagia, menometrorrhagia, hypermenorrhea, polymenorrhea. We now classify it, according to Palm Coin, as abnormal bleeding, with structural abnormalities being polyp, adenomyosis, leiomyoma, and malignancy or hyperplasia. And then the non-structural abnormalities, the Coin, coagulopathy, ovulatory dysfunction, endometrial, iatrogenic, and those that are not yet classified. The primary causes of abnormal uterine bleeding in most of our patients are going to be the structural abnormalities 20 to 40% of the time, and then the non-structural abnormalities or dysfunctions 60 to 80% of the time. And it's up to us as purveyors of healthcare to determine which category the abnormal bleeding is, and then to appropriately treat and counsel our patients. Polyps is one of the big causes as a source of bleeding, 20 to 40% of the time, we are going to see polyps in patients who have abnormal bleeding. Unfortunately, we're used to doing blind endometrial biopsies, going in and sampling the lining of the uterus. And this has a false negative rate of close to 90% in polyp diagnosis. You miss it, you don't see it. In addition, polyps with abnormal bleeding are a common presenting symptom for patients with endometrial cancer. As a matter of fact, the presence of polyp malignancy in women with abnormal bleeding is almost 24% with premalignant changes and 1.5% with actual malignant degeneration. And we want to visualize these polyps to make that diagnosis. Fibroids or leiomyomas are also a significant source of abnormal uterine bleeding. Uterine fibroids occur anywhere from 25 to 40% of the time, and submucosal fibroids are diagnosed in up to 10, 11% of women presenting with abnormal uterine bleeding. Once again, blind endometrial biopsies have been shown to have a false negative rate of up to 95, 98% of the time. And fibroids can be associated with bleeding, pain, pressure, and infertility. Hyperplasia malignancy is part of the palm coin structural abnormalities. And unfortunately, endometrial hyperplasia is diagnosed up to 4% of the time in your patients who are presenting with abnormal bleeding. Again, the blind biopsy is not going to be that good because it has up to a 75% false negative rate for diagnosing endometrial hyperplasia. Why? Because we're biopsying an area where we really don't know where the abnormal tissue is. And the risk of progression of endometrial hyperplasia to occult carcinoma, well, in complex hyperplasia without atypia, it's less than 5%. But when you have endometrial hyperplasia with atypia, it's up to 28% progression to occult cancer in 20 years. We need to prevent this. We need to diagnose this. We need to treat this. Office hysteroscopy is much more accurate than a biopsy alone. Once again, with the blind biopsy, we're not seeing where to biopsy the abnormal tissue. And when we can look inside and then biopsy as we're visualizing the abnormal area, well, that's the state of the art now. If you look at the evidence from this slide, the blind biopsy in diagnosing polyps was 11% compared to hysteroscopy, almost 90%. Sensitivity for diagnosing fibroids, 13% with a blind biopsy, and 100% with hysteroscopy. Hyperplasia, 25% versus when we can actually visualize where the abnormal tissue is, 74% of the time, we will make the correct diagnosis. The American Congress of Obstetrics and Gynecology confirms that biopsy may be insufficient. Why? Well, if the biopsy comes back positive, we know for sure that the patient has that disease entity. But if the biopsy comes back negative, we could have missed the polyp, we could have missed the fibroid, we could have missed the abnormal hyperplastic area. So a positive result is much more accurate for ruling out disease than a negative test. And the positive result is only an endpoint when it reveals cancer or atypical complex hyperplasia. Unfortunately, we're not going to see that with a blind biopsy. We're going to need to look and biopsy the areas that we see are atypical, that are abnormal. And that's going to increase our ability to find the disease and treat the disease. ACOG also supports advanced diagnostic imaging. What are we talking about? Well, we're talking about a transvaginal ultrasound. We're talking about a saline infused sonogram, and we're talking about hysteroscopy. So the SIS or sonohysteroscopy is much, much better than transvaginal ultrasonography, because we can detect the intracavitary lesions, as I'll show you in some slides coming up, much easier. However, the next step, and again, the current state of the art, is hysteroscopy. And hysteroscopy can be performed in an office setting. It can be performed in an operating room. However, in the office, it's more convenient. It's more comfortable for the patient. It's overall less expensive for the healthcare system. And the purveyor of healthcare, you, the doctor, is being reimbursed more for it too. So it's a win-win for everyone. In a meta-analysis that evaluated diagnostic accuracy, hysteroscopy had an overall success rate of almost 97%. Once again, we've got to stop the blind biopsy. We've got to look inside, and we have to sample what we can see with our eyes, and that will empower us to be better physicians and better healthcare providers. There was a systematic review of imaging studies by Maheu Lacroix, and he showed that the saline infused sonogram was superior to the transvaginal ultrasound, specificity of 92 and 89% compared with 64 and 90%. However, it lacked the sensitivity to be used alone. Hysteroscopy, on the other hand, provides direct visualization of the uterine cavity. And when you combine that with your biopsy, not a blind biopsy, but a visual proven biopsy that you're seeing the abnormal tissues, this has now become the criterion standard for the diagnosis of intrauterine abnormalities and subsequently used to treat abnormal uterine bleeding. This is a study showing the comparison of the diagnostic performance of transvaginal ultrasound versus saline infused sonography versus diagnostic hysteroscopy. And if you look at the DH, the diagnostic hysteroscopy column, it is far superior than the other two modalities for diagnosing abnormal uterine bleeding. Once again, we have definitive evidence-based medicine that shows blind biopsy is not appropriate, diagnostic hysteroscopy and visually biopsying the abnormal pathology is much more sensitive and much more specific. So as we can see in this slide, why aren't we seeing it? Well, traditional hysteroscopy requires patients to go to the hospital. That's space consuming and time consuming. It's inconvenient for the patient. It's inconvenient for the doctor. It's really not patient centric. It's a nuisance for the patient. It's painful. It requires anesthesia. And the overall cost to the healthcare system is expensive. Not anymore. The traditional abnormal uterine bleeding clinical pathway required an initial consultation in the office with the patient, a transvaginal ultrasound, an endometrial biopsy, which was blind, a saline infused sonogram, another visit to plan the following treatment, and then diagnostic hysteroscopy in the hospital and or treatment. We don't have to do all this anymore. We have simplified it, and we can bring a lot of these procedures to the office to make it more convenient for the patient, to make it more convenient for the healthcare provider, and more cost effective for the entire healthcare system. The cost effectiveness of office hysteroscopy is phenomenal. Number one, they did a study with 130 patients with abnormal bleeding. 42% were in the OR, 58% were in the doctor's office. And by performing the procedure in the physician's clinic or office, $3,500 per patient was saved. It was done with a flexible hysteroscope, minimal to no pain, and the physician was able to counsel the patients before the procedure, during the procedure, after the procedure, and plan for additional treatment all at the same time and all at the same visit. How do we do this? Well, thankfully, CooperSurgical has a vision, has a mission, and has values. And this is to create a world of healthy women and their family, to deliver impactful solutions that will improve the health care of our patients, while at the same time being ethical, passionate, innovative, and respectful. How do we do that? We have something called the Endo-C Advanced. And the Endo-C Advanced is the state-of-the-art direct visualization. I like to refer to it as something like the best thing since sliced bread. There is a camera and a docking station. There's a video monitor that sits on the docking station. It is not very big, but it's big enough for us to visualize. It's larger than the largest iPhone that you have. There's a single sterile use cannula that you'll be used to insert into the endometrial cavity. It's flexible, but it's also stiff enough so it makes it easy to insert. And if the cervix is a little stenotic, you use a little hydrodilatation while you're inserting it. 4.3 millimeters, that's less than a half of a centimeter outside diameter. With this, you can press a button and there will be still images and video capture. The camera is disposable. The video monitor is reusable. And in addition, there is a working channel. So as you're visualizing your pathology of your patient, you can actually do a biopsy or remove a polyp, and nothing is blind. Everything is visible. It has changed the way we practice medicine, especially during this time of COVID, when patients don't want to go to the hospital, when patients are fearful of coming in multiple visits. We can do so many things in one visit in our office, which benefits our patients, their healthcare, and really society in general. Broad range of uses are going to include evaluating abnormal uterine bleeding, deciding where we are on the palm coin diagnosis. We can also look at infertility and recurrent miscarriages. I've seen abnormal cavities, I've seen septum, I've seen bicornuate uteruses, all with the Endo-C in my office. Of course, we can identify polyps and fibroids. If somebody is postpartum and continues to bleed, you can look inside and actually see retained products of conception. You can see endometrial thickening and atrophy in postmenopausal bleeders, and any tissue that is in need of biopsy, no longer a blind biopsy, but a visual biopsy. In addition, we can do actual diagnostic measures and transect adhesions or a septa, remove a polyp, remove a retained IUD where the string is lost or the string is absent, do actual directed biopsies, all the time planning for additional pre-surgical and surgical activities. I'm going to show some actual sonohistograms and hysteroscopies and show how they work together, but also show how there can be false negatives and false positives. You see in this slide is a sonohistogram, and it shows an intracavitary lesion, we think. However, when we proceed to diagnostic hysteroscopy with the Endo-C, it's a perfectly normal cavity. And retrospectively, that was probably a blood clot inside the endometrial cavity that looked like an intracavitary lesion, and it was indeed a false positive sonohistogram. this could always delay treatment for a patient. In the top view, you see a sonohystogram, number 2, and there appears to be a lesion in the cavity. However, direct visualization, there's nothing there. In a very similar sonohystogram, number 3, you see another lesion in the cavity. And yes, in the endo-C hysteroscopy with direct visualization, you can actually see the polyp that is in that cavity. Now, that polyp would be appropriate to remove at the time of the endo-C procedure. Here we have a sonohystogram that shows perhaps a thickened endometrium and an irregular uterine lining. But lo and behold, when we put a camera inside and we actually look in the endometrial cavity, wow, it's just loaded with polyps, multiple polyps, that this patient would require a procedure that's going to need to remove all of those polyps and then clean that lining of the uterus to help control her abnormal uterine bleeding. You can see here that a picture is worth 1,000 words. This was a patient of mine that had a transvaginal ultrasound, and we always do the transvaginal ultrasound at the same time we do the sonohystogram. It's just the initial part of the procedure. But you can see there may, or in the left slide, the left part of the slide, the first sonogram, where it says TVUS, it looks like there may be an increased density in the center of the uterus. So there's possibly a mass there. When we then do the sonohystogram, the saline-infused sonogram, there's definitely the appearance of a structural abnormality. That looks like a large solitary polyp. And then the endo-C advance is done, and lo and behold, there is that large solitary polyp. The endo-C advance provides the clearest image of the inside of the endometrial cavity. And one can easily see both ostia, the areas of the normal endometrium, and in this case, a large solitary polyp that's going to require a polypectomy in the future. In this next slide, it's talking about postmenopausal bleeding in a patient who has a stenotic cervix. I mentioned earlier that we can use hydrodilation as we're inserting the endo-C device, the endo-C advance, into the endometrial cavity. Here we have a 61-year-old G3P1 with postmenopausal spotting, and there's some questionable echo densities on the transvaginal ultrasound. So an office hysteroscopy is performed, and we're trying to get into the endometrial cavity. We're now injecting a little more fluid, a little more pressure. As we push in, you can see the endometrial canal opening up, and lo and behold, we're now in the endometrial cavity. And we can see that endometrial cavity is beautiful. There's no hyperplasia. Up, yes, there's something there up at the right, correction, the left cornel. And there's a small polyp up there. And so now we have a diagnosis for this patient who has a polyp. And this polyp can be removed at the point of care when we're doing this endo-C because it's small enough. This patient did not require anesthesia. This is done with a paracervical block. Once again, the hydrodilation, injecting fluid while you're inserting the scope into the cervix, into the endocervical canal, empowers you as the physician to be able to do this procedure. And again, this is going to be patient-centric. It's going to be a reduction in cost for the healthcare system. And this patient's going to be cured at this one visit in your office. Here we have a patient with a lost IUD. Now, most of the time, a patient comes in and is requesting her IUD removed. We'll put the speculum inside and we'll see the strings. We'll go ahead and grab it, have the patient give me a hard cough and pull it out. If we don't see the strings, we can take a IUD hook and gently insert that into the endometrial cavity and see if we can feel the IUD. Unfortunately, many times that is unsuccessful. So here we have another opportunity to use the Endo-C Advance. This is a 27-year-old nulla gravida who wants to get pregnant and needs her IUD out, but we can't find it. So in the office, we go ahead and insert the Endo-C Advance. We're now in the endometrial cavity. We see the IUD, and we're going to look for the string. And there is the blue string over there on the right side of the slide. And we're taking our graspers and we're going to try to manipulate them to grab the string, which is inside the endometrial cavity. There's no way this string is outside of the uterus. And as we're manipulating them, we'll grab the string. And then we can pull the IUD out. We have saved this patient a bundle of money, saved the healthcare system a lot of money. The convenience of getting this done in the office when the patient showed up to have her IUD removed because there's no pre-op planning is just remarkable. This patient was able to have a successful IUD removal on the same day she requested it done, despite non-visible strings. Huge patient satisfier, much more comfortable IUD retrieval without the hassle of going to the operating room. What about reimbursement for this procedure? Well, fortunately, the reimbursement is remarkable because it's going to save the entire healthcare system thousands of dollars, while at the same time rewarding the healthcare provider for performing this procedure. So it's a win-win for our patient, for our physician, and for the healthcare system. I know in my practice, I received anywhere from $1,200 to $1,600 when I do a Endo-C Advance in the office and remove tissue or a polyp or an IUD string. And so I am comfortable saving the healthcare system money, saving the patient money, while at the same time getting an appropriate reimbursement for the work I do. So what are some of the advantages of our Endo-C Advance that we use in the office? Well, instant endometrial imaging guided by direct visualization. Once again, we're going to take the word blind out of our vocabulary, and everything is now going to be direct visualization. We can see it and we can biopsy it. And this can all be done at the same time. This device provides a very clear color display with accurate visualization. Patients experience little or no discomfort. I use a paracervical block because I grab the cervix with a Tenac. It's very efficient in terms of the office flow because this can be done in any exam room and it takes 2 to 5 minutes. And there is a low cost investment in this procedure that is going to be reimbursed. So once again, it's a win-win, not only for the patient, not only for the healthcare system, but also for you, the purveyor of healthcare. So a new clinical pathway is available. As I showed you earlier in the first part of this slide, the patient would come in for an initial visit, her history, physical exam, and laboratory values. Then she would come back for a transvaginal ultrasound and an endometrial biopsy. Then she'll come back for a saline-infused sonogram, and then we will prepare for an outpatient procedure, and then she will come to the OR. In the second part of the slide, you can see now the history and physical, and the transvaginal ultrasound, and the hysteroscopy with the Endo-C Advance, and plus or minus the biopsy, can all be done with the first or second visit. Treatment may be done at that point, or the patient can then be set up for treatment. So we're also minimizing potential multiple visits, something that is also important in this time of COVID, when patients don't want to keep coming to the doctor's office and when patients don't want to come to the hospital. So we have something that's accurate, that's efficient, that's convenient, that's patient-centric, and that's cost-effective. Telemedicine is something we're all using. We're talking to our patients on the phone much more. We are able to bill for this, which is nice. However, patients don't want to have procedures in the hospital. And lately, it's been very difficult getting patients scheduled in the hospital. Multiple times over the past year, elective surgeries are canceled or are put off for a period of time. And having the ability to work up and perform these procedures in your office has been a godsend for our patients. I explain to my patients that I don't have to bring you into the hospital to make your diagnosis, and in many times to treat your abnormal bleeding. Thanks to the Endosee Advanced, I can do most of it in the office. So as Stephen Goldstein said, this new approach to gynecologic diagnosis is having a transformative effect on the management of patients with a variety of gynecologic disorders. We have come away from operating in a closed space, in a closet, doing blind biopsies, where we can actually visualize everything in the endometrial cavity. And we can do this in our office with low cost to the patient and the healthcare system. It's remarkable what we are able to offer our patients now. So in summary, the Endosee Advance provides direct visualization into the uterine cavity. So anytime we have something going on in the endometrium and we want to see it, we can easily slide this instrument, which is only 4.3 millimeters, through the cervix into the endometrial cavity and see what's going on in there, providing us with a high accuracy of diagnosis, a decreased time to treatment, and a tremendous improvement in patients' care. On a personal note, it maximizes my time and also is cost effective both for my practice and my patients. At this point, I'm going to open up to questions, and I thank you for the time you've given us, and I hope I provided you with some food for thought. Thank you.
Thank you, Dr. Schwartz. I'm now going to turn over the Q&A portion of the program over to Christopher Kahn for CooperSurgical.
Thank you. Excellent talk, Dr. Schwartz, and it's great to speak with you again.
Thank you, Christopher.
Great, and thank you to our audience too for your time this evening. My name is Chris Kahn. I'm the Senior Global Product Director at CooperSurgical. I'm seeing your questions as they're coming in, and feel free to keep them coming in. I see them in real time. We're going to try to get through as many of these as possible this evening. And for any additional questions we don't get to, or for additional follow-up, please do check the box for a sales representative follow-up in the polling questions at the end. Okay, let's get started. So my first question, Dr. Schwartz, is what is the most important factor for you in choosing to use Endosee Advance?
I think that the fact that it is so convenient to use and empowers me to perform a high quality of medical care right in my office.
Okay, excellent. Thank you. We've had some questions about pre-medication. When, if ever, do you choose to pre-medicate your patients before using Endosee Advance?
I rarely ever pre-medicate my patients because the actual cannula is so narrow and so flexible. It's extremely easy to insert into the endometrial cavity. I would say of the last 100 patients that I've done in the office, I may have pre-medicated 2 of them with a mild dose of Valium that they took the night I gave it to them to take early that morning, but it's extremely rare. And those are the same patients that might need Valium just for a regular pelvic examination. But pre-medication is not really an issue with this product.
Okay, and if you had a patient that was concerned about pain, do you use any sort of pain medication?
I do. I'm one of those physicians who use a paracervical block for anything that I'm putting in and out of the uterus. I even use it for an IUD, and the patients are always saying, wow, the last time I had that done, nobody gave me pain medicine. So I think number one, Psychologically, it's extremely helpful. What I do is a paracervical block. I use 2% lidocaine. I put about 4 cc's at 12 o'clock, 4 cc's at 4 o'clock, 4 cc's at 8 o'clock into the cervix. I have them cough like that as I inject it so they never feel the actual needle. Then I put an additional 8 cc's between 4 and 8 o'clock, a little deeper. And then I'm getting the product set up. So I will turn on the machine, turn on the camera, turn on the video monitor, hook it up, attach the tubing to it, and input the information, the patient's social security number, et cetera. So that's all about a minute or 2 minutes. It gives a chance for that block to set. Then I do the procedure and the patients tolerate it extremely well.
Okay. And do you ever find the need for lubrication of the cannula?
I have never found a need for lubrication. I really don't want to use, I know Surgilube or Vaseline, all those things could be used, but you're just going to be pushing more bacteria into the endometrial cavity. I've never had an issue again with this cannula because of the size of it. Now, another tip and trick is if you inject a little saline, so that's hydrodilatation, as you're inserting the cannula in, it kind of gives you your lubrication that you need, or even dilates minimally the endocervical canal as you're doing the procedure.
And when you use that technique, do you find that you're successful in most cases, or, what percentage of patients do you find that to be a successful strategy for?
Well, I also have a os finder as part of my setup in the office. And if there's difficulty inserting the cannula, then I will go ahead and use the os finder and then insert the cannula. But I can't remember the last time I tried to do an endoc. I can't remember any time I tried to do an endoc in the office that I was not successful in entering the endometrial cavity, with the exception of someone who had an ablation and was bleeding, and we were making an attempt to look, and there wasn't a cavity to look into.
Okay. And we've had a few questions about distending the uterus. Do you have a preferred method, and why do you choose it as far as using a syringe or an IV bag?
So my preferred method is a 60 cc syringe. In the kit, we have these little baskets in our office, and in the basket, they put all the equipment we need, and they're just set up the day before, or there's a couple always available. And we will go ahead and have 2 60 cc syringes. Most of the time, I just use one. Rarely do I need a second 60 cc syringe. And then very few times, if I'm actually doing a polypectomy and it's going to take me longer than a minute or two, I will have a bag of 500 cc saline and just hang it with gravity. And that's more than enough to provide distension and the fluid. But in answer to your question, my preferred method is going to be just using the 60 cc syringe. It's just so convenient.
Okay, great. Thank you. And then there's been a couple questions also about clearing the view, the visualization during a procedure. How do you handle that?
Okay, so sometimes there's a little bit of blood on the end of the camera. I will insert the endoc all the way up to the fundus, and I'll push it on the fundus a little bit, and essentially to wipe off the camera and then pull it back. And that's usually all it takes to clear it.
Okay. And there's a couple questions about how you use the images after the procedure, both from showing the patient any pictures or videos you took, and also uploading into an EHR. Can you speak to your preferred way of handling that?
Sure. One of the beauties of this is that the patient's awake, the patient gets dressed, and then I go back in the room and I talk to the patient with her clothes on, and I actually show her the pictures that we took. I show her the pathology or the lack thereof. Then the actual video monitor goes to the front desk where it's downloaded into my EMR, and it's just part of her medical record. It's simple.
Okay. and you were showing some cases about therapeutic procedures. Can you speak to your experience removing a polyp and how successful you are in doing that? Is there any, criteria you use in terms of size of polyp that's appropriate for office use?
Sure. First, I'll say one of the best benefits of this is you can see where the pathology is and you can sample the pathology that you're seeing. And I think that's very, very important. Gynecologists in the past have always been operating in a dark space in a closet and doing D&Cs and polypectomies with our really blind. We didn't see what we were doing. Now we're able to see exactly what we're doing. So diagnostically, we can sample the endometrial lining, an area that's hyperplastic. If there's a small polyp, 1 or 2 centimeters, I will go ahead and remove it at the same time. If it's a little larger than 1.5 to 2 centimeters, I will then probably reschedule them for a procedure in which I have some type of morcellation device to remove it, just because it'll be a lot quicker. I probably could remove a 2 or 2.5 centimeter polyp. However, I think it would take a long time, and it would be easier if with one of the morcellation devices that I have in my office, and I do these procedures in my office.
And if you are going to do it in your office with Endosee Advance, do you have a preferred instrument that you use?
Well, the Endosee Advance has a polyp forceps that you can purchase, and I have 1 or 2 of those. There's a disposable one and a reusable one. I use that for biopsying and for removing small polyps.
Okay. Okay. Here's one from a doctor asking about the postpartum uterus and difficulty maintaining distension. How do you approach that?
So I would think that this physician is thinking about retained products of conception. And anytime you do a hysteroscopy, we want the cervix tight around the hysteroscope. And so whether it's a usual hysteroscope that's 6.2 millimeters, or this very tiny, essentially, hysteroscope, we have to have the cervix tight around it so we can distend the uterus. I will many times take a tenaculum and grab the cervix at 12, and then again at 6, and maybe at 3, and maybe at 9. So that's 4 tenaculum, or it might be called tenaculi, excuse me if I'm wrong. And that will cause the cervix to tighten around the hysteroscope. In the OR, I've put stitches around the cervix. I put endoloops around the cervix, but it's just as easy to go ahead and grab with a tenac. Another tip and trick is to go ahead and grab it at 12 o'clock and then re-grab where you grabbed it and then re-grab it again. And if you just have 2 tenacs, and each time you're tightening that cervix around your operating device, the Endosee in this situation, and then you're going to distend the uterus with fluid.
Okay. This next one is a concept I'm not familiar with, but I assume you will be. Do you ever use laminaria ahead of time for difficult patients?
So the problem with the laminaria is it's going to dilate the cervix much more than the diameter of the Endosee. So you're going to have the problem we were just talking about with fluid leaking out. I always have an os finder available with me. And usually I can use the os finder, which is a very, very narrow dilator. And then gradually it gets bigger as you push it in. Now, in those rare circumstances with a postmenopausal woman with a very stenotic cervix, I would probably, rather than put a laminarian, because that's going to dilate the cervix too much, is give her some Cytotec the evening before. And then I've never had difficulty getting the os finder in.
Okay. Speaking of os finders, where do you order yours? Do you order them in bulk, or do you get them through the convenience kit?
I order them through bulk, I think. I apologize. I'm answering this question and I'm not 100% sure because my office staff takes care of that for me. I'm sorry.
Okay. Um, Here's a question about patients on blood thinners. Are you comfortable doing this procedure in this population, and do you do anything different?
I don't do anything different. I am very comfortable doing this in this population. We're not cutting anything. We're not causing any bleeding. There might be a little bit of bleeding from dilating the cervix, but it's never been an issue.
Okay. Can you tell us about your experience removing malpositioned IUDs with
Yes, and
Endosee Advance?
this is an excellent device for that. Patient comes in, wants her IUD removed. I go ahead and put the speculum in, and lo and behold, I can't see the IUD string. So the first thing I'll do is take an IUD hook and see if I can feel for it, twist it around, and pull the IUD out. If that's not possible, I'll then, and many times I'll just do it at this same visit, get the Endosee set up, put the Endosee in, and then as you saw in my talk today, you can easily see the IUD string, which sometimes is taking a sharp right turn and going back up to the fundus, and you just go ahead and grab it, and then you pull the whole Endosee and the grasper out at the same time.
Okay. Thank you. We've had a couple of questions about reimbursement. What is your experience with these procedures being reimbursed in the office?
Especially during the times of COVID, this has been a godsend for me. I have not been able to do a lot of minors, or at least back in April, May, June, and July in the operating room. They're starting to open up now, but it has really empowered me to continue practicing medicine at a level of excellence. We're able to do these procedures and get appropriate reimbursement. The trick is you bill for the procedure and you bill for the facility. There's a facility fee. And Anthem in Southwestern Ohio many times will pay $1,600, but even Medicaid will pay $600 or $700. We have CareSource here, and we've negotiated with them. And so if I went into the hospital and did this procedure in the hospital, it would be $5,000 or $10,000, and I might get 150 to 300. I do it in my office, and it's a win-win for both the insurance company and us as physicians. And of course, for the patient, because of the convenience for the patient.
Thank you. In which ways have you found this product to make your office, your practice more efficient?
Well, it empowers me to do things when they need to be done. I don't have to go ahead and spend time having my staff call the OR, getting the patient to do pre-op scheduling, pre-op testing, and come into the OR. This is a simple procedure, like putting an IUD and like doing an endometrial biopsy, that we can do in the office without any pre-medication, without any pre-authorizations. It's so convenient, not only for the patient, but for my practice.
Okay. This next question is about doing biopsies. And when you're using Endosee Advance with an EMB, do you use the Endosee Advance first and then EMB, or vice versa? How do you approach that?
I always do the Endosee Advance first because I want to see where the abnormal tissue is. If there's generally no abnormal tissue, I'll put a pipelle in and just get a general sampling just to confirm that there's no precancerous changes, no hyperplasia, no issues going on, and I can proceed with whatever procedure we are going to do, like an ablation or a hysterectomy. If there's a specific area I'm concerned about, I will use the Endosee biopsy forceps and actually go in and visually biopsy the suspicious area. And this is now the standard of care. It should be the standard of care. It's a state of art with medicine rather than doing blind biopsies. So you want to see first, biopsy second.
Thank you. And thank you for your time this evening, Dr. Schwartz. This last one is more of a comment. I think Dr. Karen Stewart is looking to reconnect with you, network with you. She was in Cincinnati back in the 80s, and she was wondering how long you've been there practicing in Cincinnati.
I finished my residency in 1982, went on the faculty of the university for 2 years, and I've been in private practice ever since. So my email is D as in David, B as in Bruce, doc, that's DOC, the number 8 at AOL.com. And Karen, reach out to me. And anyone else that may have a question, feel free to reach out to me.
Excellent. Thank you so much, Dr. Schwartz. Excellent talk tonight, and thank you for your time with the question and answer.
Thank you so much for the opportunity. Have a good evening.
All right, thanks everybody. That's going to conclude our Q&A for this evening. As a reminder, CooperSurgical will follow up with any questions that the speaker could not get to this evening. Please take a few minutes to complete a brief survey about tonight's program. It is at the bottom of the screen. It says post program survey. Just click that button and you can fill out the form. Thank you for joining us and have a fantastic evening.